everybody. We're here today at the Mexican meeting 2025 with Dr. Thomas Chi. Thank you so much for being here with us, Dr. Chi.
My pleasure.
So we're going to have a small interview. We wanted to ask you a few questions about your presentations today. And the first one, and I think is the most important one, when do you start shifting from fluoroscopy to ultrasound guidance access in the percutaneous surgery?
So I actually trained as a fluoroscopy-guided PCNL surgeon. So I did prone, fluoro-guided access for all my PCNL.
Okay.
And it was visiting people. International exchange, I think, is so important. And I had an opportunity to go to China where they do a lot of ultrasound. And I met a guy there named Jiangxin Li, and he showed me what he did, and I thought, wow, that's pretty amazing.
Okay,
and so we had
great.
the chance to work together to figure out how can we learn from you and then teach what you do in a way that makes sense for a non-Chinese set of learners. So that was back in about 2013 to 14. And so over the next couple of years, we tried to figure out how do we adapt things to ultrasound. And so pretty much since then, I've gone almost all to ultrasound now. So I do mostly ultrasound guided access, ultrasound guided dilation, and 99% of my cases now, we don't even have fluoro in the room.
Oh, that's great. And can you share with us that learning curve from changing from a fluoro guy all the way to ultrasound guy? How was that learning curve?
Sure. So we've learned a lot over the years. So the learning curve, the way that I did it, I probably wouldn't recommend. Dr. Lee was very nice. He just sent me a video, an old video of his, and I just watched it over and over and over again and then practiced his moves. And so it probably took me about 20 cases to get okay at it. But then since then, we teach it very routinely now. So we teach people about imaging first, and then we teach people how to hold their hands. And we use models and a lot more kind of step-by-step instruction. So now my trainees, my residents, my fellows, they can usually learn this skill after about 5 or 6 cases.
That's really
so
it's a small learning curve.
It's a small learning curve, and it's very different than it was before. So I would recommend you learn it from somebody who knows how to teach it.
Yeah, for
Don't
sure.
just watch it off a video.
And any tips from everyone that wants to change or shift from fluoroscopy to ultrasound?
For ultrasound access, people worry about the needle control, but I actually think that the better you are at ultrasound imaging, the faster you'll learn how to do this skill. So my recommendation always is ultrasound as many kidneys as possible. So when I first started out, I put an ultrasound machine in my clinic. I had one in the operating room, and every patient that came to my clinic, I ultrasounded their kidney. So if they came for testicular pain, I ultrasounded their kidney. If they came for a kidney stone, I ultrasounded their kidney. And so the patients like it because they feel like he's taking such good care of me. Yeah. And for me, I'm just practicing, so everybody wins.
You're getting used to the kidney and see the imaging and everything.
Absolutely. Getting used to the imaging is critical. So the more familiar you are with the imaging, how to interpret it, and also how to get a good picture, the easier the needle access will become.
Okay. And what about these pelvic kidneys that you sometimes just to get, I don't know, in your practice, you also do ultrasound?
Absolutely. So one of the advantages, I think, of ultrasound is that it can be used for pretty much most any anatomy. Pelvic kidney is a great example. Transplant kidney is a great example. Those are actually, in many ways, very easy to do because they're very close to the surface of the skin. It's kind of easy to find the kidney, and while the anatomy might be malrotated, it's easy to actually find the kidney and find a good entry point. And so it's those types of cases that we probably used to use, we would probably use CT guidance to put a needle in. Now you put an ultrasound on there and you can get right in.
And what about, I think this is a little bit of a step that we struggle a lot. What about the dilation with the ultrasound? Because I think for fluoroscopy, it's really easy. You just put the balloon dilator and it's already there. But what about this? You're holding the scope and then you're holding the wire. What about the dilation during the ultrasound guided access?
So the ultrasound guidance for access, I think, is definitely easier than mastering dilation. Most of my fellows, by the time they finish fellowship with me, they can do both. Most residents probably feel very comfortable with access, but maybe not so much with dilation. So it's definitely a longer learning curve. The key is that when you're going to dilate, you have to be really good at imaging so that you can watch the wire very carefully. Because once the needle's in place, the needle's fairly immobile. It stays still. But once the wire is in place and you're imaging, you have to actively image to find the wire. So that makes it a little tricky. The other thing is that, to your point, the instruments we use are fluoroscopy instruments. So we're adapting them to ultrasound. So right now, when I dilate with ultrasound, I find the wire, which is very bright under ultrasound, and then as I advance my dilators, it covers the wire up. So unlike fluoroscopy, where I'm looking for the tip of the dilator, which shows up under fluoroscopy, I'm looking for the wire to disappear.
Okay.
And that's how I know where the tip of the dilator is with ultrasound. So it's a little trickier to master.
It's different, a little bit different, but you're looking for the same thing. And you usually use like one-step dilation, like Amplats or balloon dilation?
So the majority of my cases are now mini PCNL, and I'll use oftentimes a single-step dilator.
Okay.
Sometimes, maybe I'll backtrack a little bit. I'll use a fascial dilator first and then go to the kidney renal access.
Okay.
So it is a serial dilation of sorts.
Okay, serial dilation. Okay, and I think just to finish this up, I always like to ask, if you could only have one laser in your clinic, just one laser for your practice, which laser would you use?
Well, the SMU had a terrific debate today on which laser is the winner, holmium, thulium, YAG, and I got to play the luxury of being the holmium person. So today I would buy a holmium laser.
Okay.
I think it has a lot of uses. It's a lot of flexibility, good for soft tissue, good for stones. But I was very compelled by Mantu Gupta's argument on the thulium YAG. So we'll have to wait to see what that data looks like and how it actually performs in people's hands. But it's a lot of exciting technology. So it may be that thulium YAG will be the winner.
Yeah, I think it's going to be a lot of improvements in the next years for the lasers. Well, thank you so much for your time. It was amazing and a pleasure having you here in this meeting. I hope you're also having a great time.
I've really enjoyed Guadalajara, and the SMU meeting is just spectacular. So thank you very much.
Thank you so much.